Hello, this is Andrew Colsky with Stop My OCD and AnxietyEnders.com. And I am really excited today because we have a new subject that I've been wanting to talk about for a long time. We have Howard Gurr, who is a virtualist clinician who works with therapy and virtual reality. And Howard, could you please introduce yourself to the audience?
Okay, thank you, Andrew. So I'm a psychologist. I've been in practice, I hate to say this, but 40 years. I work primarily with people who have phobias and anxieties, and I use virtual reality as my therapeutic modality and tool to speed up the process of the treatment of anxieties and phobias. So I'm a clinician on Long Island, New York. I know the background doesn't look like New York. It's actually, I think it's Los Angeles, but I always like that background. So it's a lot better than my office. I'm just kind of like I see myself as your run-of-the-mill clinical psychologist who's just a bit of a geek.
Great. Well, I consider you an innovator in the field, and I'm really happy that I have the opportunity to talk to you about, what you've been doing. And virtual reality is such a big thing these days because of all the new technology that's coming out and all the different options. But you got into virtual reality, a while ago. So can you tell us, how did you even come up with the concept of using it for therapy, and what was it like when you first started?
Well, I call myself a watcher. I was waiting because I got into the idea of using virtual reality therapy probably 25 years ago. And what really prompted it was I came across an article about Skip Rizzo, who is in California, who's been doing virtual reality for the longest time. And Skip had a virtual classroom, and it was designed to identify and potentially treat children who had ADHD. And so the child was immersed in this virtual environment, and you can control the distractors that were going on, whether, I guess, there were cars or trucks passing by, or the kids were talking, and you could track the child's eyes and see where they were focusing, and then you could use that to train them to kind of refocus. So I contacted Skip, and by the time I got to him, he already had sold it off and wasn't really working on that anymore. And he was really focusing on PTSD with returning soldiers from Iraq and Afghanistan. And I kind of like lost my steam because that was the drive. And then about 3 years later, I came across a company that was called Virtually Better. And they had a PC bound system. And I tried to convince them to buy a portable laptop that I came across from this company in Texas that met all of their specifications in terms of the requirements. Because in those days, there were two things that were very significant. One was you needed tremendous processing power. So you couldn't just use a regular computer. And number two, the head-mounted displays were rather clunky and heavy, and everything was ludicrously expensive. So a setup might have cost $100,000, which is not something a clinician like myself could afford. And so I waited and waited and waited. And around 2015, I came across this company called Sios in Barcelona, and they used Samsung Gear phones as the engine and Samsung Gear VR headsets. And so I contacted them, and they sent over a representative who sat down with me, and we went through all the environments. And honestly, a lot of the environments were entertaining, but I didn't get a sense of, presence or even, stress. And at the last minute, the representative said, "Oh, let me try one more thing." And I have to tell you that I'm not great with heights. And not that I'm completely phobic, but I just don't like being in high places if I can help it. And so he said, let me just try one more thing. So he put me in this virtual environment where I walked out to the end of a balcony on like the 80th floor of a building. Now I'm in my office. I know where I am. I'm standing in my office, and he says, okay, take one more step. And I said, I don't think so. And I went, I got it. Okay, I got it. So I could feel that my brain would not let me take that one more step. And so from that point on, I bought into the system, and I spent, I don't know, 3-4 months playing with it, bothering all my friends and relatives, anyone that I could get to kind of experiment with it. So I got more comfortable with it. Because before I was going to introduce it into my practice, I wanted to make sure I really had, mastery over this. And so from about the beginning of 2016 on, I've been using it in my practice for patients who have phobias, anxieties, even generalized anxiety, overstressed individuals who just forget what it feels like to be relaxed, because you can use it just to train people to be relaxed. And so I've been using it ever since. And I've, over the years, beta tested other companies. So when I started, Virtually Better basically was the only major player in town. I've been keeping track of companies, and I'm up to 114 companies in the behavioral health realm of virtual reality. Now there are other uses, and obviously there are other players, but just in behavioral health, it's gone from like 1 or 2 to 114. And so there are a lot of companies that kind of like develop since the pandemic, because the pandemic opened up the idea of using teletherapy and using alternative techniques to reach patients and to help patients. So this is kind of like blossoming of companies all over the world in this realm. And so I've kind of consulted to several of them and beta tested and given them reinforcement, or told them what I think that they should be looking at in terms of systems for therapists. And then over the years, I've been giving webinars and training to help kind of spread the word. And the last thing was that about, I guess, 3-4 years ago, I got frustrated because people would call me up. I'm licensed in New York State, Florida, but people would call me up from all over the country saying, could you help me? And I couldn't. I'm not licensed in those states. And so I would look for therapists even in those states, and I couldn't find them. I couldn't find therapists who were using virtual reality. So in my frustration, I developed a directory. It's called virtualtherapistinternational.com or vrttherapist.com. And I was trying to come up with a listing of therapists who use VR in their practices so that the public can find therapists, and therapists can also refer to one another and communicate with one another. It's been a slow process, but I'm still working at it. And I think it's just, we need to kind of solidify the community and make it a more, I guess, an amenable approach that clinicians can pick up and use in their practices as well.
Great. Wow. There's a lot of info in there and a lot of things that I want to follow up on. But before I do that, I want to take a step back. Okay. Can you share with the audience, before you had access to virtual reality, how would you do your therapy? What did you do? If someone comes in your office, how do you handle it?
Well, so to me, virtual reality, I mean, essentially, it is a tool that enhances exposure therapy. Now, other people use it for different things, but my strategy is to use it to expose people to a virtual environment. Because prior to virtual reality, if someone came in and said, like, I have a fear of flying. So in the beginning, you'd sit in the office with them and you'd say, okay, here's what I want you to do. We're going to sit here and I want you to imagine that you're on a plane. And I'll, do whatever I could to kind of help them use their imaginative skills. But people are terrible at trying to hold on to the imagination image that actually provokes anxiety. Why would you want to do that? And so you have to do that. And then eventually you'd either have to go on a plane with them or set up someone else to go on a plane with them. And the same thing for driving. People who have fear of driving, eventually you had to be in the car with them. So it was very time consuming. In the beginning, it's very difficult and there's a high dropout rate because people become frustrated. And then towards the end, it becomes very time consuming. And I don't necessarily want to be in a car driving with other people. So it becomes cumbersome and difficult. With the advent of virtual reality, all of that's taken out. So I don't rely on people having to imagine them sitting in a plane because I'm feeding that information and I'm feeding it as many sensory modalities as I can. So, for example, if someone has a fear of heights, they're in a virtual environment, but I might put a fan in front of them. And so now they're in a height and they're feeling like wind. And what happens is when there's enough presence and immersion in that virtual environment, the brain kind of gets hijacked. And so now, even though they know where they are intellectually, the primitive part of the brain is just in that virtual environment. And so the brain reacts exactly the same way as it would in a real life experience. So the virtual environment became as close to real life as possible. And we could use the virtual environment kind of systematically by increasing the severity or intensity slowly and allow the person to adjust and accommodate and kind of basically quiet down the amygdala and the sympathetic nervous system so it doesn't overreact. Mm-hmm. So with traditional therapy, it might take me 6 months, 7 months to get somebody to where I want them to be. With virtual reality, I can do it in 8 sessions.
Wow. That's a huge time savings.
Yeah, very, very cost effective. And I just think it's I'll give you an example. Very early on, I had this woman who called me from Colorado. And she had a fear of flying. And I guess it's like 2017, maybe. And she found my name. And I said, listen, not that I want to turn away business, but there's got to be somebody doing this between you and me. All right. And so I did look up and I found a couple of names of people who were closer than I was. Mm-hmm. And she said, no, I'm coming to you. She drove from Colorado to New York. Mm. I spent 2 days with her. And she drove back. And she's been flying ever since. I still keep track of this woman. And she must have had at least 50 flights.
Wow.
Since we worked together. And that would never happen in traditional therapy. It just couldn't. I've had similar cases like that. I had a guy call me up. He had a fear of heights, and he booked a trip to Amalfi in Italy, but didn't look at the itinerary. Now he looks at the itinerary and he realizes the entire place is cliffs. And he said, I can't go. And I said, well, give me time. It was like June and his trip was in August. So I had like 6 sessions with this guy. He went on the trip. He took the trip. And he wrote back to me. He said, not that I love heights. He said, but I could tolerate it. He said it was like an 80% success for me.
Wow.
Again, not something that could happen in traditional therapy.
Right. So here we are in 2023, mm-hmm. and this is sort of a multi-part question. Can you explain to us, number one, if someone wanted to get therapy using virtual reality with you, for example, would they have to come into your office is one part of the question. And the second part of the question is there additional cost to them? And then the third part of the question is, as a therapist, what is the cost to you?
Okay. So prior to the pandemic, people would come into the office. But since the pandemic, the platform that I use allows me to do everything remotely. And so patients, everyone has a cell phone, pretty much. And so the only thing people really have to get is a rather inexpensive head-mounted display that you can get for like $25 on Amazon. And so they use their phone, they buy this inexpensive head-mounted display, and I, in my office, control their cell phone and remotely put them in virtual environments that, and work as if I was with them. And so to them, that's the only expense. I bill virtual reality the same way I bill standard traditional therapy, because the way I look at it is virtual reality is real therapy. The virtual reality is just a tool. And I say to people, if I had somebody a fear of dogs and I brought a dog into the office eventually, would I bill that separately? I don't think so. To me, that's just part of the therapeutic process. So to the patient, it's not anything extra. It's also, from my perspective, I haven't had a problem getting reimbursement from insurance companies. So in general, it's reimbursable. I don't participate in most insurance companies, but the ones I do, there's no problem. And I've also had single case contracts with other people who have insurance companies that I'm not on, just to kind of do them a favor. And the insurance companies had no problem when I explained what I was doing. So I know that VR in the behavioral health realm is reimbursable. In terms of what it costs for providers, it's rather, every system out there has some kind of subscription fee. And so there is some kind of cost in terms of monthly cost or annual subscription fee to use the platform, unless you create your own platform, which I know you're doing. But I think when people subscribe, they have to look at that as a business expense. And I think one of the problems is that clinicians don't see themselves as being in business. And so they don't understand the concept that, you have to look at things from a return on investment. And that's because of our training. None of us are trained in the physical, in mental health world to perceive ourselves as being in business. And you get a degree, and most clinicians have no idea how to run a business. They know how to do therapy, but they have no idea how to advertise, market, or get clients. They figure, I have an office, a telephone, and a business card, I'm in business. But I always try to tell clinicians, listen, even if you bought a psychological test, like an IQ test, it might cost you, I don't know, $1,600 for the test, maybe even more. I don't know what it costs anymore. But it's an expense. And I think that you have to look at it, well, what's my return on that expense? And I think as in this particular time frame, virtualists are minorities. On Long Island, there are probably 1,000 licensed psychologists in Suffolk County, which is Long Island's made up of Brooklyn and Queens are part of Long Island, but they don't see themselves that way. They're part of New York. Everyone else is like Long Island. So Long Island primarily is Nassau and Suffolk County, 2 counties. And there's probably 1,000 licensed psychologists in each county. I'm not even counting licensed marriage family therapists or mental health professionals, whatever, because there are other credentials. But I only know about the psychologists. And I could count on my hands, maybe my right hand, the number of clinicians that I know are using VR. So it's really a niche at this point. And I
Mhm.
think the clinicians need to see it as, if you have a niche, well, that's good for business. Um, and in my situation, about a third of my patients are referred to me by other clinicians. So what happens is that somebody in the middle of their therapeutic process might say to the therapist, "Oh, I have to go to Florida in a month, and I haven't flown in 20 years. I can't get on a plane." Well, they're not really going to be able to address that fast enough. So they send them to me. I kind of get them to the point where they can do what they need to do, and I send them back. And I don't really step on the clinical toes of the clinician in terms of what they're working with, in terms of other things. I'm very focused on working on the phobic response and reducing it. And so I don't really get too enmeshed in the other clinical issues. It's like I'm, technician. And this is what I do. This is where I get you, and go back to your clinician at this point. So I think it's a very potentially lucrative field, but we still don't have mass awareness or mass acceptance of VR as a clinical tool.
Yeah. Well, so that leads me to my next question, which is if a therapist happens to be watching this podcast and
Mhm.
they are interested in exploring VR, is there any particular training that they need to have or should have?
Well, I think VR can lend itself to a lot of different um, therapeutic styles. But my core is that, because the way I work it is that I think my VR treatment is based on three major things. So it's cognitive behavioral therapy. It is psychoeducational therapy,
Mhm.
and it's kind of uh, focused on physiological and body awareness. Those are the three prongs, so to speak. And I think that um, there aren't too many places yet that provide training. I know there are people out there who offer training. So Elizabeth McMahon does training in workshops and has her book, which I think is a great book.
Mhm.
Um, I know that the platform that I use, which is now called Amelia, has ongoing training all the time. And they offer training and offer manuals and research. And so if they provide it, I'm assuming other companies do that as well. Um, there are organizations that are just beginning to develop that are oriented towards extended reality and in therapeutic and medical modalities. And for example, amxara.org is kind of a new organization in the mixed reality realm that wants to establish training programs for clinicians, because we don't have anything to kind of credentialize this and organize it. In the old days, it was the old days. Currently, still on some levels, it's kind of like you got to figure it out yourself, and that's what I did. In 2015, 2016, I just taught myself what I needed to learn, and then developed over time, because I found every patient had a certain uniqueness to them and a certain need that standard platforms can't really address. And I know you know that
Mhm.
very well. And so it was important to kind of be creative on some level and think outside the box and come up with virtual environments that might meet an individual's needs. Um, so there's really not, you still on some level have to think a little like Dr. Frankenstein at this point, because you have to piece things together sometimes to make it work for an individual client. Um, but I'm hoping that systems uh, like the one you're developing will eliminate some of that difficulty, because clinicians need it simple, And to get mass acceptance, it has to be, plug and play, so to speak.
Right. No, I agree. And just for the benefit of the audience, the system that Howard is referring to is, I'm building out my own company, for full disclosure, called Prescription XRT. And what I'm doing is trying to take a look at all the current cons and work around them and turn them into pros if possible. And I'm excited about what I'm building, but we're still in the development stage. We're close, but we haven't launched yet. But that brings me to my next question for you, which is, so we've talked a lot about the benefits, and they sound like there's some really very good benefits of using VR in your practice. What are some of the cons?
I think the major con still to me is that VR companies haven't really been able to develop the packaging I think it needs to make clinicians jump at it, because clinicians are, I guess, very conservative in general and very cautious, and they're not going to jump onto something or absorb something into the practice that they don't feel fully trained in. And since there's very few programs that actually provide VR therapy training in their graduate programming, people come out with no understanding or knowledge, and since they're not comfortable with it, they're not really going to jump on board. Interestingly enough, I know here on Long Island is Hofstra University. They have a VR setup, and they train their graduate students to use it. And I'm assuming that there are other places like that, but just not enough. So I think part of the problem is VR doesn't have the mass awareness and approval and acceptance in general. And among clinicians, it seems to be something not plausible to absorb into their practices. So I think that's a downside. In terms of my work, I think I see more pros than I see cons, because it works efficiently, and because of I guess, almost the entertainment value, it hooks people faster, and I have less dropout rates and more compliance. So the uniqueness of it makes it, I think, more desirable for patients to kind of follow through. And the other piece is in my platform is I can give people homework assignments, virtual homework, where they can do that at home. Mostly it's just all of the anxiety reduction and Jacobson muscle relaxation and diaphragmatic breathing, that kind of stuff that they could do at home, that they don't need me, and it speeds up the process. So it works very well, but I think the downside is probably marketing.
Mm-hmm.
If I had to come down to the major problem, is it's just because it's just not enough awareness. And the thing about VR is that it has its waves, its ups and downs. So early, in the 2005, 2004, it was great. It was going to be the thing. 2016 was the year of VR, and it came and went. And we have all of these major companies battling for VR and XR space, but it's still, I believe, somewhat in its infancy, and it hasn't really had time to grow. Of course, the standard statement is that as a clinician, it takes 20 years for some technology to become absorbed and widely accepted in clinical experience. And although VR has been around for a long time, I estimate we're at year 8. So we have like a bunch of years to go before we get mass acceptance.
Right.
So I think there's time for it to grow and prosper and congeal into a smarter package. But as I said, I think we're just not there yet.
Yeah, as you're talking about it, I'm thinking back myself, and when it was about 2015 or 2016, I looked into virtual reality as a clinician because I didn't know what was being offered. I didn't know it was out there. And I looked at some of the tools that were available. And at the time, my concerns were I really wanted to be able to use it. But what I looked at was, number one, it was extremely expensive for me as a clinician to purchase and then pay the continuing price for it. Number two, I had at the time to have a client come into the office to use the headset and the technology that I had to set up in my office. Number three, the scenarios available were extremely limited. And it's like, well, I can't use this for most of my clients because unless they meet, one of these 5 scenarios, it doesn't mean anything to me. So there were a lot of drawbacks, and I'm like, so I'm going to pay how many thousands of dollars for something that I can't really use? It didn't make sense at the time. Now I know since then they've added a lot more scenarios and things have improved. But I think those are still some of the roadblocks, as well as, like you say, clinicians not knowing about it. And, anytime it's something new or different, there's a level of fear or uncertainty from the clinician side. So, along those lines, are there any stories that you have from your own practice where using VR didn't go so well with a patient?
Listen, like everything else, we have our failures. I will tell you the interesting. I had one case where the woman put on the headset. I don't think she lasted 5 minutes and developed a vertigo response. And she said, "I can't do this." And we tried it again. She said, "No, can't do this." And that was a particular failure. I've had people who dropped out, just like any other therapeutic approach. But I think here's my perspective. I think as a clinician, everyone has like a particular area of specialty. And I think that if you could use VR in that specialty, great. I think if you try to become a generalist with VR and enter territory where you're not trained or not comfortable, I think there's a problem. So, for example, I'm not trained in substance abuse issues. My wife is, but I'm not. But I don't take clinically, I don't take patients who have substance issues because I don't feel that I should be stepping into territory that I don't know. And I feel ethically and morally responsible to stay in my lane, so to speak. And so I use the VR, and it's not that every single patient in my office uses a VR. They don't. But when I think it's appropriate, I pull it out of the toolbox. And so I have patients who, come in with all sorts of long-term issues, conflicts, family issues, whatever. VR is not really appropriate under those circumstances. So that's why I look at VR as a tool. I use it when it makes sense. And so I think that's the way I think you have to look at it, because you can't conquer everything with VR. Now, there are people out there who work with senior citizens, dementia patients. VR works well with them. There are people who work with autistic children. VR works very well with them. There are people with eating disorders. VR works with them, but I'm not trained in eating disorders, so I'm not going to use it for that. So I think it has that flexibility of being able to be used, as I said, when it makes sense and when you are trained in that. And I think that, going back to your earlier statement about the virtual environment, what I found is that, let's say somebody comes in with let's say fear of driving, and the VR driving environment may not really evoke enough anxiety. It's not realistic enough, or it's not exactly the kind of road situation that gets them upset or causes conflict. I may use a completely different virtual environment that has nothing to do with what they came in with. because I need to just invoke the anxiety so I can work with them. So I might put them on the edge of a building, even though that's not what they came in for, because I know if that invokes enough anxiety, now I have something to work with. And now I have an environment where I could train them to use the skills and tools that I need them to use to handle the other environment. And if they can get through that, because from my perspective, the skill set is the same. Once you learn how to handle your anxiety, and you could shut off the sympathetic nervous system, it works no matter what you're having difficulty with, because it's the same problem. The brain's doing exactly the same thing.
Right.
So I think that, again, but you have to think outside the box. And that's one of the things that clinicians sometimes don't do, because they're trained, well, this is what you came in for. But with the virtual environment, I mean, it's if you have something that works, that's next to it, near it, close to it, touches it, whatever, you could use that and still gain the same advantage.
Yeah. Yeah. Well, I want to ask you sort of the magic wand question here, which is, so you have a lot of experience with this, and you know a lot about what's going on in the field. If you yourself had the ability to wave your magic wand and make the perfect VR system for the type of clinical work that you do, what would it look like?
The perfect situation doesn't exist. I don't know if it will ever exist in my clinical lifetime, but the perfect situation would be a virtual environment in which I, as the clinician, and the patient are in the same virtual environment, and I could create the virtual environment completely tailored to whatever that patient's difficulty is. So if it's, someone has a difficulty talking to 3 people in a group, I want to be right next to them in this situation where they're talking and I'm now coaching. I want to be there. I want to say, okay, now let's look what's happening. And I would want intelligent avatars in this virtual environment so that they could have a natural kind of conversation that would just flow. And it wouldn't be, scripted in any way. It would just be interactive, which we do have the capabilities of doing. But I think that I want to be there, because the thing is with virtual reality is that when you do VR, there's really only 2 ways that it works. Either the patient's in a VR environment and I'm outside the environment, or we are in the same virtual environment. Now, when a patient is inside a virtual environment and I'm outside, there's a dilemma. And the dilemma is, how much should I be talking? How much? Because the more I talk, I'm kind of on some level ruining the presence and immersion of the person being in that environment, because this kind of like disconnected voice is coming out of nowhere, And so I want to minimize that. But if I'm right there with them, then we could have the complete conversation. And so I guess my ideal circumstance would be the holodeck from Star Trek 2.
Yeah.
That would be perfect to me, because the avatars in that particular environment were completely responsive, and you plugged in exactly what you wanted. I want to be in a saloon in 1800, and I dress up in my Western garb, and I walk into this room, and bing, it becomes a saloon, and you could be standing there next to the patient and just literally doing therapy on the fly and talking to them about what's happening and how they're coming across and what the other person is seeing or not seeing. Everyone always thinks that everyone knows I'm upset or anxious, and of course that's not true. But being able to work that would be phenomenal. It'd just be unbelievable.
Yeah, and I don't know that that's unrealistic in terms of what might be coming down the road, because I was just having a conversation yesterday with someone who was telling me about an event that Mark Zuckerberg was part of, and he was talking about photorealistic avatars that because right now today they're cartoonish, but you combine photorealistic avatars with a AI generated virtual environment that can be whatever environment you want. We probably could do it today. It would be very clunky and hard and expensive, but I don't know that that's unrealistic as we look down the road.
You know what? It's not unrealistic, and they're very close. There's actually a company in Norway called Simly, and it's a startup. So it's only available in Norway. So, but they have an AI algorithm. They only work on social anxiety, and so they have a beta out there, which I could send you the link. It's a beta. It's a job interview, and so it's just an example. But I played with it a couple of days ago, and it was absolutely phenomenal. I mean, just phenomenal. The interviewer interacted like 98% like a human being.
Wow.
And it wasn't scripted. And it wasn't like the old days. The old days they used to have these computer programs where the avatar would give you standard answers like, well, how do you feel about that? Or what would you want to do? But they would just pat scripted answers. This just seemed much more realistic. So they're like one step away from being there. And so this is a little startup company. If somebody had some major bucks, the gaming individuals, the people who make games have major money to invest in games, but we're not investing that kind of money into therapeutic tools because I guess they don't think the market's there,
right.
But it could be there.
Right.
So I think you're right that we're closer than ever. But I think that to me would be ideal. And the ability to individualize each session to the standards or needs of that patient makes it very useful. Because right now we have these kind of like standardized computer generated videos, but they can't meet everybody's requirements. Like I have people who say, well, I don't like roads that have a sharp cliff-like on the side, where there isn't a guardrail, and I always feel like I'm going to drive off the road. Nobody creates a virtual environment like that. And so I've had people who've had that difficulty, and I would have to go online and find like 360 videos that somebody had recorded of some, windy mountainous road. And I would say, okay, now we're going to use this. And that would work, but it's not in my platform. I can't control it. And so it's a matter of having to kind of do it from a distance and not have control. Since the pandemic, obviously, I said I haven't seen patients face to face, but when you don't see face to face, you lose a few things. And so I lose heart rate variability and galvanic skin response data, and I can't use another headset with something else. So for example, in Oculus, there's a game called Richie's Plank, which we call, actually Les Posen calls it the low-bearing fruit of virtual reality, because almost everybody responds to this. And what it is, it's a game in which part of the game is you're in an elevator, and the elevator doors open up, and you're on about the 80th floor of a building, and sticking straight out of the elevator is a plank in the middle of the air. It's just sticking out there. And you have to walk on the plank to get like a piece of cake and bring it back into the elevator. And in the Oculus with a 6-degree freedom, you're walking, and you're literally walking, and the plank is creaking while you're walking on it.
Wow.
And I set this up in my Oculus, and again, my brain, I know I set it up, but the problem is that I try to step off the plank. I want to see what happens. I know what happens when you step off the plank. You literally go down. And my brain won't let me step off the plank. I just can't do it.
Yeah.
And so I think that the level of intensity, because it's a game, and obviously someone had more money to invest in it than the therapeutic tools that we use. So the realism is incredible. But when that kind of money gets invested into, psychological tools, we'll see a huge jump. Because, as you know, it's costly and time consuming, and it's not like, putting a crystal radio together.
Right. Right. No, that's I've seen that particular situation used for the concept. Same reason that you just said, when people are sort of naysayers about virtual reality. Oh, that's not going to be real, and they say, okay, go ahead and walk the plank, and whoa.
Yeah.
So it makes the point that, oh yeah, it's real.
Yeah.
So and that's the thing. I mean, the virtual reality options that I've seen out there are very good for what they do. It's just they don't do as much as I would need, and they don't do it at a cost that I could afford in many cases if I'm the average, clinician, not specializing in this or something. So as we begin to wrap up here, I have one more question for you.
Mm-hmm.
And that question is based on what you personally know about the industry, because I know you follow the industry. What do you see realistically happening with virtual reality, mixed reality therapy in the next 5 years and the next 10 years?
So I think that there are a lot of players trying to develop packages and systems that will work for therapy. I think in the next 5 years or so, there's going to be a lot of consolidation, and some people are going to be successful, and some people are going to be absorbed and bought into bigger packages. I think there are going to be a couple of major players in the next 5 years who are going to take over, and I think that 10 years down the road, this is just going to be standard practice. I think clinical skills are going to be very different. If you go back, I don't know, 6-7 years ago, when all of these teletherapy companies started coming out and offering therapy in a teletherapy market, and the clinical reaction to that, the general reaction was, oh, that's not therapy. That's not real therapy. Real therapy is face-to-face, in the office therapy, and anything else is just, sham.
Mm-hmm.
Well, comes the pandemic. Now, all of a sudden, all of those naysayers are doing therapy via teletherapy. Now, all of a sudden, it's okay. Now it's acceptable. Now it works. Okay.
Right.
And I think that VR and extended reality is like the next step where people will say, oh, that's like parapsychology. It's not even real. That's game. But I think once all of a sudden it becomes much more accepted and polished, and it grows and matures, all of a sudden it's going to be acceptable. It's going to be, oh yeah, that's therapy. We understand that now. And I think that's the next 5 years. And then after that, I think it's just going to continuously become honed to the point where I think therapy is actually going to be very different as a field I think we're going to be approaching problems from a very different perspective because technology will become accepted and extended reality will become so polished that it'll just be like, oh yeah, so that's what we do.
Yeah. Yeah. No, I agree with you. Just seeing the speed of things changing the way they are. I think it's inevitable that that's just what it's going to be, and I'm excited to kind of watch it as it grows.
Yeah.
So now here comes the lawyer in me. I'll ask the last question.
Oh.
Is there anything that I didn't ask you about or we didn't get a chance to talk about related to therapy and virtual reality that you think is important and I just forgot to ask about?
I don't know if there's anything you forgot to ask about. I think there are things that we couldn't touch on because time is a limit. I think that my concern in general is that therapy works, virtual therapy works. Clinicians have to become more flexible, and I think that they have to become more accepting. And I'm hoping that the younger generation, the people who grew up with technology in their hands all the time, who now are entering the field, are much more comfortable with technology and more accepting of its use, so that it's not going to be this immediate resistance that we have right now. I think that from a legal perspective, the only thing that always kind of concerns me is ethical issues and HIPAA compliance. And I think that those are the two things that have to be addressed to reduce resistance among clinicians. There are these roadblocks, and one of the roadblocks is that it's not real therapy, or the virtual reality gets in the way of the therapeutic relationship, which of course none of that's true.
Right.
And then of course the ethical issues of I'm providing therapy from a distance, and how what does that do, and how much jeopardy is the patient in, or I'm in, or are there negative impacts because of virtual reality? Does virtual reality cause problems or cause irreversible damage to somebody? All of this is just the questions that come up. It's just not true. And then the last thing is that if I'm using a system, a platform, how much data does that platform have on my patient or myself? And so I think that's where the HIPAA compliance issue comes in. And so, for example, in my practice, for the most part, according to the system I use, most of my patients are anonymous. Unless I give them a homework assignment, and then I have to link them up. But I've clarified with them exactly what data they collect, and they tell me they collect very little, if anything. And that's important. So I think the ethical issues are something that has to be addressed, and security. But I think with any technology, we have that fear that there's another person in the room with me. There's another system watching what I'm doing. And so I think from the legal perspective, that has to be addressed with any system that we create.
Yeah, no, it's interesting you say that, because that's a very big point that I have been working on with my developers, because they come at it from the standpoint of, oh, you could collect this and collect this and collect, oh, you look at all the stuff you could do. And I keep telling them, absolutely not. I want it stripped down. I don't even want the ability to put in information about the patient other than what's absolutely necessary to activate the technology. Yeah, you could go. I mean, I know there's a lawsuit right now on I think it's against BetterHelp for what they were doing with metadata. I was just watching a video about that yesterday. But yeah, you're right. So that's something that's very important to people and very important to me as I build my own platform. And it's like, I don't even want the ability to put it in. And I know there was another company I was looking at, I forget which one, that also stresses the same thing. They do everything they can to strip out any info so it can't be compromised because it's not there.
Right.
So
I think that is one of the bigger roadblocks for clinicians, because we're all trained so strongly on ethics and HIPAA compliance. And we know, I mean, like even the thing with the Oculus, which I always had difficulty with Oculus only because I was always concerned that, Facebook, or whatever they call themselves these days, um, Meta, whatever. But I always thought that they were collecting data. So I didn't like a platform that used Oculus unless they used like an enterprise version of it. But the enterprise versions were expensive. So an Oculus Enterprise was like $800 just for the device. And depending on what your model is in terms of your business model, is it possible that, if you're going to do this on a regular basis, some people might buy, 5 or 10, devices and then loan them out, and then, charge people if they don't bring them back, whatever. But that's not something most clinicians are going to want to do.
right.
So, and even hospital systems, I mean, we can get into long conversations about introducing VR in medical systems and the problems of medical systems accepting VR or any kind of technology without thinking that they're going to get a return on their investment. Because, if you do that, you need to like create almost a department. So now you have somebody who's in charge, now you have somebody who manages, and are you going to get your money out of that? I don't know. They don't know that yet.
Right.
So I think that there's all sorts of issues that leak into even just the equipment, not just the platform itself. So I can understand why people are a little spooky, but I think that you have to be careful and you have to know what you're doing, so that you don't violate other people's rights, your patient's rights.
Sure. No, and that's another, one of the reasons that, my personal take on it is that the patient uses their own cell phone. I don't have any technology, number one, because it's too expensive. And number two, data collection issues. It's not an issue if I don't have anything, I have nothing to collect anything. So, those are all very important issues. And I think you're right. Those are going to be bigger and bigger as we get further and further into implementing technology like this into healthcare. So it's an interesting area. I'm glad that we've had the opportunity to talk about it, here. And a couple of years later, come back and listen to this podcast and see where things are compared to where we were today.
Yeah. I think it's going to move very quickly.
Yeah.
Hopefully, and I was waiting for Apple to venture in to see what they were going to do, because they generally don't jump in until they figure that all the errors out that everyone else made. And let's see when the next 2 or 3 generations of their devices bring to the table.
Yeah. Well, I want to make sure that I ask you to give the website again for your directory, so that if somebody wanted to go to it and find a therapist who provide a virtualist. Let me put it that way.
Virtualist, yeah.
What is the website again?
It's www.vrttherapists.com.
Okay, so it's got 2 T's, VRT therapists with an S.com.
Yeah.
Perfect. All right. Well, Howard Gurr, thank you so much for your time and your insight today. This is a real treat for me because it's an area that I'm personally very interested in. And, I'm excited to see what the future brings for us.
Thank you, Andrew. Thanks for having me. And it's great talking to another virtualist.
Thank you.
Okay.